نمر إلى المحاضرة الأخيرة في هذه السيشن update in management of cardiovascular complication. وأعطي الكلمة أستاذة سلاف إبراهيم.
Thank you very much for giving me this opportunity, Professor Inas and the organizing committee, to participate in this workshop. I really envy Prof. Nizar and Prof. Abir for having the easier part. And really, cardiovascular complications are, there is a lot to be said about it, and I will try to do my best to make it as simple and practical as possible. Over the past 2 days, we have been hearing a lot about the cardiovascular outcome trials وشفناها كلها وعرفنا إنه كل واحدة تدي لشنو. I will try يعني to be practical, what we are really and actually doing in our clinics. Before I start, maybe I'd like to see some hands up. When you get a patient in your clinic, a diabetic patient in your clinic, how many of you will think about assessing the cardiovascular situation of such a patient without the patient complaining? Good. Few hands up. How many? We know our clinics are very busy, very short time. How many of you will not remember unless the patient complains? Then you will think of doing the assessment. No one? I think it is something natural, ya Ikhwana. It is not a mistake. It is something natural. Unless we have protocols or we have guidelines set up for us, remember or reminders that every patient, every diabetic patient, whether you see him for the first time or you have seen him repeatedly, that remember the cardiovascular part, because it is one of the major mortality causes of mortality in diabetics. We have seen in one of Professor Nizar's, his first slide, cardiovascular was number 1. Okay, the learning objectives of this presentation would be to identify the cardiovascular complications of diabetes, and a short introduction and the mechanisms, the treatment, and I will just highlight on a few of the cardiovascular outcome trials, and then our take-home message. Okay, just a reminder. I know you all know this. Just a reminder so we are all in the same wavelength. These are the short-term complications. You agree with me. DKA, hyperosmolar, mentioned by Professor Abir this morning, and hypoglycemia. These are mainly the emergencies. Then the long-term. Sorry, I hope the writing is evident. The nephropathy, retinopathy, microangiopathy, the neuropathy, and then the heart disease, the stroke, and the atherosclerosis. All these are important. In fact, when your patient comes and sits in front of you, these are the things that come to your mind. Mainly in the ambulatory care, of course. The patient is out, you are in your clinic, and these are the many complications. Maybe my patient is having so and so and so. Okay, regarding cardiovascular complications, to be more specific, we think of chronic heart disease, the diabetic cardiomyopathy, renal disease, and stroke. All these are, of course, related to the microangiopathy and the changes that occur in the endothelium and the vascular endothelium, leading to atherosclerosis. So it is the atherosclerosis that leads to all these complications. Again, when your patient is sitting in front of you, diabetes, hyperglycemia comes to your mind, hypertension, dyslipidemia, smoking, is the patient a smoker or not, and the predisposing risk factors. Just at a look at him or her, you will be thinking of this patient needs to really reduce the weight. And of course, you will have had his weight and height, and his BMI, family history, and the physical activity. Okay, just a small and short introduction. We have a lot of epidemiological data showing that type 2 definitely will increase the cardiovascular risk. You all agree to this. 1/4 to half, 25 to 50% of patients with diabetes develop cardiovascular complications. And approximately 58.9% to 77.8% of all diabetics will develop evidence of cardiovascular complications. Evidence from earlier trials have demonstrated that improvement in glycated hemoglobin will reduce the risk of microvascular disease, but still there is lack of evidence to suggest whether the improvement will have similar beneficial outcome on the macrovascular disease. The risk of cardiovascular disease is twice in people with diabetes as in people who do not have diabetes. Prospective epidemiological and experimental studies have reported an association between the suboptimal glycemic control, an elevated A1C, and both micro and macrovascular complications. And it is worth note that even in the pre-diabetes phase, these people would have started to develop the changes. So it is not after the patient develops diabetes, it is at least 10 years before in the pre-diabetes phase. This is just to show you the numbers that every 1% increase in the hemoglobin A1C will increase the risk for coronary heart disease and stroke. So if a patient comes with a hemoglobin A1C of 10, that is why we rush to start the insulin and try to control because of the cardiovascular and the stroke problems. You will be alarmed, but the patient doesn't know. He will not be alarmed. But remember, as advised by Prof. Nizar, not to alarm him. Give it to him very slowly. In recognition of the graded relationship between glycemic control and cardiovascular events, a major shift has taken place in the recent years to develop evidence-based treatment strategies for type 2 diabetes that will not only reduce the disease progression but also reduce the chances or risk of developing cardiovascular disease and prolonging life. These numbers are very alarming. Atherosclerotic complications, 80% mortality among patients with diabetes, 75% patients developing coronary artery disease, more than 75% hospitalizations for diabetes complications. Not very cost effective. 50% of patients with type 2 diabetes have pre-existing coronary artery disease, and a third of them presenting with myocardial infarction have undiagnosed diabetes, presenting for the first time. This is the most serious part. They come in with myocardial infarction, then they develop, you will discover they have diabetes. So, how does this happen? How do we develop these endothelial problems? Just a couple of slides. The hyperglycemia exerts a negative role on endothelial function and leads to the pathological changes. The four major molecular signaling mechanisms, the activation of the PKC, increased hexosamine pathway flux, increased advanced glycated end product formation, the age range, and increased polyol pathway flux. Because this is not really the scope of our talk, I will just go very quickly about. We're back again to insulin resistance. Insulin resistance itself has been found to be linked to cardiovascular disease. It is an independent predictor of cardiovascular disease, and it is closely linked to a number of cardiovascular risk factors. And it may develop 20 years before the onset of type 2 diabetes. And 50% of newly diagnosed patients will show signs of coronary vascular disease. This is just a table to give you an idea of the things that come to your mind with your patients with diabetes. This is the Framingham study, showing us that the relative risk ratio, the total cardiovascular disease, and patients with heart failure and hospitalized for heart failure, patients with peripheral vascular disease. Peripheral vascular disease, acute or chronic limb ischemia, are usually quite forgotten by us. Because going back to the teamwork, diabetes is teamwork, you all agree. And the vascular surgeon should be part of this teamwork. We should start training our junior staff to check the peripheral pulses of all patients who come to them. It is very, very important. I'm sure we are missing it. Okay, so management, we come to the management of our cardiovascular complications. Okay, management, when we talk about management, we mean lots of things. Like, first of all, It begins with, anybody can help me? How would management begin? Managing the patient coming for the first time. Sorry? No. You're in your ambulatory care clinic. في العيادة ما في emergency setting. Patient جاي, he's a diabetic for his usual follow-up or for the first time discovered to be diabetes. قبل قلنا إنه we need to think about the many things. There are many things. The high blood sugar. We need to think and consider the cardiovascular. Our talk is on cardiovascular, so we need to think about it. How are we going to go about it? Any ideas? Yes? The blood pressure and peripheral vascular assessment. Sorry? Obesity, symptoms, lipids. So we can summarize all this as history taking. We take a detailed history of the patient and then we examine. We ask about everything in the history, the duration of the diabetes. We take note of the age of the patient, his occupation, where he comes from, what he is doing, his physical activity, if he's physically active or not, his diet, smoking or not, very good. Alcohol as well, family history. Sorry? Past medical history. Okay, and if he has other history of other diseases and the medication he's taking, the drugs, yes, very good, thank you. The medication that he's taking, it's very important with the doses. And another important thing, the compliance. Is this patient compliant or not? He might be taking all these medication and he's not compliant. الفايدة شنو؟ And the diet he is taking, بتاكل حمية بتاعت سكري مظبط السكر بالأكل، يقول لك أيوة. لكن when you come and take a detailed history, you find that he is doing the wrong thing. This is very, very important. عشان كده we need the teamwork, the dietitian, the diabetic nurse. Just a comment on the diet part. Some patients would like to hear it from us, from the physician. It's not that they don't trust the dietitian, but you take your time and give them more information on the diet, and then send them to the dietitian to reinforce your work. Okay. Having said all this, we took the history, we examined thoroughly the patient. Nowadays, when the people, or maybe we are busy, our junior colleagues with us in the clinic, they are very busy, they do not examine the patient thoroughly, especially the cardiovascular system. طبعا من history we ruled out the ischemic pain, stable or angina or unstable angina, the chest pain that comes with exertion and all these things. Measuring the blood pressure, checking the vital signs, auscultating the heart. Auscultating the heart, you can discover dilated cardiomyopathy, مش كده إذا كان الapex beat deviated and all these things. People would just request chest X-ray, echo, ECG. الثلاثي المرح بس عشان أريح نفسه. لكن لا, it is very important that we listen to the heart. We examine the cardiovascular system, examine the liver, the abdomen. Remember the peripheral vascular system, the feet, the pulses in the feet. Medical history, physical examination, and then of course appropriate laboratory tests, you all know. Sometimes in some countries, and as we have heard over the past 2 days, there are the risk stratification forms. Some countries have their own risk stratification forms. You can find them online, cardiovascular risk. There are a lot. If I don't know if in Egypt you have a unified one or not. In Sudan we don't have one, honestly. But one just unified. Okay, that's very good. Madam Framingham, okay, that is good. At least try to, yes, a mobile app. At least try to risk stratify your patient. Where is this patient? Is he mild risk for cardiovascular disease, moderate, wala severe? And then according to each risk stratification, there is an action according to the score itself. Okay? Then, after risk stratification, and by risk stratification here we can detect, by examination we can detect clinical cardiovascular disease, by the risk stratification the subclinical part, and we might even go on, if the patient has severe risk for cardiovascular disease, we might even need to go on for further cardiac assessment in collaboration with our cardiology peers. This is just a comment on the risk stratification. Evidence from the randomized control studies is still lacking. The ADA consensus stated that patients with established coronary artery disease or have had a prior cardiac event, this is a difficult category. Already they had a cardiac event or with established cardiovascular high risk, then these are the patients that go to be tested. Patients without a prior risk or an event or symptoms strongly suggesting cardiovascular heart disease, you have to warrant testing for this category. If they have any one of these 5, then they go for testing. Either typical or atypical cardiac symptoms, arresting ECG suggestive of ischemia or infarction, peripheral or carotid occlusive atrial disease, a sedentary lifestyle, etc. Cardiac testing is as follows. Exercise stress test, which is, I think, affordable and cheaper than the rest. We have stress perfusion imaging, stress echo, or even cardiac cath. We need here the help of our cardiologist to assist us. This type of testing we need to refer to a cardiologist depending on the severity of the underlying or suspected coronary artery disease. This is another comment on the metabolic syndrome you're all aware of. There is no pharmacological drug that can reverse it, al-hasal, and we need to treat the major factor, which is insulin resistance. Okay, so we have evaluated the risk, we have stratified the risk of this patient. Patient جانب الأول عملنا الhistory, physical examination, we requested our labs, and we stratified him according to whatever risk stratification form you have. Now, we need risk intervention. We need to evaluate the other things. يبقى تكلمنا عن ال body mass index, عن ال obesity, عن smoking, the lipids, the blood pressure, renal function. We need to work on those as well. If we don't control them, ما في فايدة. These are the risk interventions we need to do. Cessation of smoking. We have to be very serious about this. Treating the hypertension. We go to our basic guidelines and see where we are. Control the blood sugar. Early insulinization if needed. Make sure the patient is taking the sufficient or the appropriate type of treatment. And the compliance, of course. Lipid management. We all know statins are the best till now. Weight reduction. A programmed weight reduction is much better than just a simple weight reduction or exercise technique. Remember primary and secondary prevention. Primary prevention of thromboembolism. Secondary prevention if the patient has already had cardiovascular events or stroke, the ACE inhibitors, the beta blockers, and the antiplatelets, of course. Okay, so till now, we're very practical. Our patient came to us, we did all this, and we did our risk intervention, machine ways, we checked his labs, and accordingly, we are happy with this. So, just a quick look over the cardiovascular outcome trials. سمعنا عنها كتير over the past few days. Just a reminder. There has been recently a paradigm shift from in the form of the trials. Initially, they were mainly dealing with tight control to reduce micro and macrovascular complications, but then until recently there has been a change into concentrating more on the cardiovascular risk, altering the study designs, the duration which they are conducted, and the endpoints that are being assessed have been changed. They focus now mainly on cardiovascular death, fatal or non-fatal MI, and stroke. This is the famous ADA AASD guidelines with the new and the previous or older medication. I think you are all aware of this, and you know how to start and choose your medication. This is just a diagram I just like because it sort of it gets all the trials together with the dates they are being set up on. You can check that. This is another one, the same. You can check that in the guidelines, in the websites. This is the UKPD, the famous UKPDS study, which showed that there was an intensive arm, intensive therapy arm, and the regular conventional therapy arm, and it showed that in the first 10 years post-intervention, there was no significant reduction in all-cause death, stroke, or composite of any diabetes-related endpoint, but of course it had reduced the microvascular complications. But in the next further coming 10 years post-intervention trial follow-up, significant risk reduction were noted for MI, all-cause mortality, and furthermore with the metformin group. The ACCORD, again, it showed a significant decrease rate of non-fatal MI, but it was stopped because of the premature increased relative risk for all-cause mortality that occurred, mainly in the intensive group. Then we have the ADVANCE trial, the Veterans Affairs Diabetes trial, RECORD and PROACTIVE study. RECORD is the rosiglitazone study, and it showed an increase in heart failure in those patients and increased hospitalizations. And as well, this is just a table showing you the SGLT2 inhibitors, Canada-PA and EMPA, their status and their ongoing. It's worth mentioning the EMPA-REG, which is now the most recent one, and the study, there was the empagliflozin was given at a dose of either 10 milligram or 25 milligram versus placebo on cardiovascular events in adults with type 2 diabetes at high risk, those with high cardiovascular risk, and a follow-up of 3.1 years, there is significant lowering rates of death from cardiovascular cause, hospitalization for heart failure, and death from any cause. As shown here in this graph. Just a reminder, because I know we saw it a couple of the past 2 days. So coming to the end of my presentation, our take-home message is always remember cardiovascular risk in all our diabetic patients. Stratify the patients, go and do your risk intervention adequately, individualizing your patients. As we saw, not one suit will fit all. Identify patients with cardiovascular complications. Remember your primary and secondary prevention measures. Teamwork is very important. Carefully choose the appropriate treatment, individualization, according to your local or versus your international guidelines. And thank you very much. We still have a long way to go. The horizon is still not clear. Thank you.
Thank you, Dr. Salaf. We have a time only. This is very nice and updated lecture. I think there is a lot to say about the cardiovascular disease, but we have only the time for one very short question and very shorter answer, because the other session will start soon downstairs, please. Is there any question to Dr. Salaf, please?
Thank you.
أريد أن أشكر الشكر الكبير للإخوة المحاضرين، وأريد أن أؤكد على أنه التوعية السكرية أن حيث اليوم والبارح كلها تمشي في إطار كيف ننصت للمريض، نعطيه الوقت اللازم، نفهم مشاكله ومخاوفه وهواجسه، نعرف كيف نتأقلم مع الوضعية الاجتماعية، الوضعية النفسية للمريض، ونأخذ بعين الاعتبار الإمكانات المحلية. لا يمكن أن نرفع السقف عاليا بحيث كان المريض لا يستطيع أن يشتري أو أن الدواء اللي أقترحه عليه غير موجود. ما بمعنى آخر، ما هي أهون الحلول؟ لأن المشكل ديال السكر مشكل طويل، مشكل، ولا نكثر من النصائح في حصة واحدة. نعطي الأولويات. ما هي الأولوية بالنسبة لهذا المريض فيما يخص هذا الشخص؟ الأولويات تختلف من مريض لآخر. وهنا تذكرني كلمة أستاذي في بداية سنوات الطب الأولية، قال لنا: ستكونون أطباء إن شاء الله، لكن ليس بعد أخذ الدكتوراه، ستكونون أطباء في آخر حياتكم. وأعتقد أنه فيما يخص السكري كلما مر الوقت استفدنا من غلطاتنا، من نقائصنا، من تجربتنا، وأن نحتاط. تفوتني بعض الكلمات من العربية دقيقة. نحتاط من كلامنا، أنه بعض المرات بدون شعور قل هذا المريض كاتاستروف، لا شيء، لا نفكر مليا أننا أمام شخص عنده تاريخ، عنده شخصية، عنده نفسية، وأنه كل أمال ويتعلق بالطبيب والفريق الذي هو يقصده. فنكون حذرين ونعرف كيف نبسط الأمور وكيف نزرع الأمل، لأنه الأمل دائما، الحياة ما دامت هناك حياة فهناك أمل، وأنه نبحث عن أهون الحلول.
شكرا حضوركم. وأنا مرة أخركم في نقاش طويل، بس ملاحظة واحدة. أرجو اليوم خميس، بكرة جمعة، نفكر شو استفدنا من هالورك شوب، شو ممكن ترجعوا فيه على عيادتكم. إذا في نصيحة بقى لكم إياه هو نقطتين: واحد، الهدف هو المريض. اثنين، أسوأ مثقف هو الطبيب الذي يريد أن يجري تثقيف بعيادة غرفة انتظار مليئة. فكروا بأسلوب ثاني وراح تشوفوه بسيط جدا وغير مكلف. عليكم أن لا تفصلوا التثقيف من المعاينة الطبية، وليس هو التثقيف الصحي السكري شيء إضافي. خلينا نتابع مع بعض في موضوع سكول اوف دايابيتس. سجلوا حالكم، رح نلتقى ونتحدث ونعمل ونتابع الموضوع ونساعدكم. هي كبداية نتمنى أن نستمر. شكرا لكم، شكرا لكم جميعا.
تنبيه بعد إذن السادة الدكاترة: الشهادات بتاعة الورك شوب هتتوزع وقت البريك على ستاند الجمعية. شهادات الورك شوب هتتوزع